Hello, everyone. My name is Sandra Alexander, and on behalf of the Circular Clinical Care Single-Use Plastics Reduction Project Team and the Canadian Coalition for Green Healthcare, it is my pleasure to welcome you to today's webinar. In just 30 minutes, we are going to be summarizing the past 16 months of work on the business cases and case studies that we have been able to undertake with the financial support of Environment and Climate Change Canada that has allowed us to start formulating practical answers to the question of how can a hospital reduce single-use plastic waste? Just like the broader national project, we approach the development of the business cases and the case studies through structured assessment, stakeholder engagement, and we have collaborated with Hamilton Health Sciences, which is a large network of hospitals in Hamilton, Ontario, to even pilot select projects and measure their impact. And so today's webinar will be a reflection of that work, followed by how these cases will be integrated into the broader project work and made publicly available. And so with that, I would like to welcome my research associate, Tipu.
Thank you, Sandra. And hello, everyone. We're so delighted to welcome you all from so many countries, facilities, and departments. We do encourage discussion throughout today's session, so please feel free to use the chat to introduce yourself. And if you'd like, share your facility and role. My name is Tipu, and I'm a research associate at the Canadian Coalition for Green Healthcare. I support the Circular Clinical Care Project in a number of areas, including the development of business cases and case studies. And today I'll be sharing some highlights from that work. Now, common across all the cases shared today is their structure. And so to begin, let's walk through the underpinning frameworks, including the key pillars we use for executive audiences and the subsequent pain points they're designed to address for green teams. And so this slide introduces the business case framework we developed to help hospital teams bring sustainability initiatives forward in a way that resonates with executive decision makers, thinking of it along the lines during development of the Charles Gritzner definition of geography, looking at the system and identifying what is where, why it is there, and why we should care. And with that grounding, we've built this model that's shown here on the slide, and we found that business cases are most compelling when they speak clearly to three core priorities: risk, cost, and patient safety. And as initiatives move forward, those priorities need to be supported through ongoing evaluation and adaptation, and that's only part of the picture. In our conversations at forums and events, we've heard repeatedly about the real-world challenges that teams face when they try to advance this work within their own organizations. And so, in addition to the three pillars that help make the case at the executive level, we also identified three common pain points that need to be addressed to support implementation on the ground. And so here are the three implementation challenges we heard most consistently from sustainability teams as they pertain to what could be included in a case study. The first is the need for persuasion to build momentum. This involves a clear and defensible account of an initiative's environmental impact, particularly one that reflects the realities of a specific facility. And so that's an account that can defensively quantify how much plastic we can reduce and its impact at the organizational level across several branches. And the second is demonstrating the potential for both environmental benefit and cost resilience in a way that can scale across different sites. Continuity, more often than not, we found, depends on this fiscal consciousness baked into the model. And the third is the need for adaptable implementation frameworks, tools that allow teams to take a successful example, many of which we'll share today, and quickly assess how that same model could apply within their own facility context. And so these considerations aren't treated separately, they're integrated throughout our work. And you can see here how both the business case framework and case study frameworks reflect the executive facing pillars while also addressing the practical implementation needs that we've heard from sustainability teams. And so together they help to ensure that projects are not only persuasive at the decision-making level, but also usable and adaptable at the grassroots level. Each of the project's focus areas could support a much deeper discussion, such as those that we had during Plastics Week. And so to help orient today's lightning session, we'll use this compass as our guide. We'll begin with perioperative care and then move clockwise through the remaining focus areas. And for each initiative, we'll use this consistent structure to review what was implemented, where it took place, the environmental benefits achieved, and associated outputs, which will oftentimes be cost savings. And so we'll begin with perioperative care, which represents one of the most significant opportunities to reduce single-use plastics in hospital settings. And I'll highlight two initiatives here, one within the operating room and one beyond it to show how these approaches can work across different care settings. And from there, I'll introduce the adaptation engine, which helps address one of those key challenges we heard from implementation teams, and that's applying successful examples within their own facilities context. The first initiative is something that you may be familiar with. It involves switching from sterile bottled water to municipal tap water for predefined low-risk and non-sterile gastrointestinal endoscopy procedures. While this approach is not exclusive to the coalition, our implementation pathway followed the work that we supported at Hamilton Health Sciences in Ontario. And in this case, the primary plastic avoided was PL325, which is a copolymer composed of approximately 80% ethylene and 20% polypropylene. And during the pilot phase, this change was associated with an estimated reduction of about 33.6 kilograms of carbon dioxide equivalent emissions and about 24.7 kilograms of plastic waste avoided per month, along with approximately $10,000 in annual cost savings. One of the key takeaways from this project is that low-risk substitutions can maintain clinical practice while reducing both material use and operating costs. This next initiative takes us beyond the operating room and shows how existing successes can be adapted and applied in different care settings through an interdisciplinary approach. And so the second initiative focused on patient belonging bags and was supported by Yul Neve, a master's student from Radboud University in the Netherlands, who joined the pilot team on the ground in Hamilton last year. And so with a background in behavior change, Yul helped explore the messaging and engagement strategies that are most likely to support uptake and participation by patients in the initiative. The pilot asked patients to bring their own reusable bag for day surgery rather than relying on single-use plastic belonging bags. And at Hamilton Health Sciences, we found that the primary plastic reduced through this initiative was polyethylene, and that translated to a minimal projected reduction of at least 4.67 grams of plastic and about 26.7 grams of carbon dioxide equivalent emissions per bag avoided. And taking figures from accounts from across Canada and other hospitals that have implemented this initiative and applying our minimal estimate suggests that this could amount to as much as saving 7 kilograms of plastic and about 40 kilograms of carbon dioxide equivalents per month. And these greenhouse gas emission ratios are based on plastic production alone, and that's consistent throughout all the examples that we share today. And in this case, the cost savings also depend on the overall reduction in bag use, and those figures are still being refined with our pilot site. Another product of this work was this conceptual framework, which was developed for the project's case study, and it draws on the health belief model and intersectionality-based policy analysis frameworks. It maps the different factors that can shape patient participation in bringing their own bag. And the key point I'd like to highlight here is that a person's decision is influenced by several interconnected considerations. And so at the center of this model are the modifying factors. And one of the key findings from Yul's research was that framing this initiative in terms of an environmental benefit may help to actually encourage participation of patients, particularly when that message resonates with the target audience, as we found. And so the next question then is, how do we translate these insights into something that teams can actually use when making the case locally? And I'm very pleased to share the adaptation engine we developed to support that very next step. And so this is a tool developed to be used alongside some of our business cases and case studies. The adaptation engine helps translate a successful example into something that can inform local decision-making through informed and evidence-based inferences, whether that's a conversation with quality councils about switching from using tap water or bottled sterile water to tap water and low risk and non-sterile gastrointestinal endoscopy, to having conversations with infection prevention and control, or making the case to operational leadership. It's a tool that is audit ready at all of those stages, and it's designed to be transparent in its assumptions, adaptable to your own facility's data, and structured in a way that supports planning as teams explore feasibility moving forward. And so this slide shows a snapshot of that tool in practice for tap water in endoscopy. It supports teams at multiple stages of implementation. In the pre-pilot phase, it allows you to estimate potential environmental and cost impacts using your own facility's data if you were to undertake a pilot. And then during implementation of that pilot, should you wish to move forward with it, the interim checkpoint section helps track progress and compare projected and realized outcomes. And so once local values are entered, the spreadsheet produces some visuals automatically, and everything shown in green on this slide represents a calculated output that's generated by the tool. And this helps makes the assumptions behind a proposed change visible because you can click on any of those outputs and see the equation that went into materializing them. And so here are some of the visual outputs that the tool produces and what we found during our pilot phase. And through our pilot work at Hamilton Health Sciences, that figures like these can help make the case at the executive level. We describe this as an approach designed to be audit ready. The engine's user friendly, and you can examine each assumption shared with colleagues in accounting or procurement, operations, and work within a structure that's already been tested at our pilot site. And so if you'd like to be notified when the spreadsheet and case studies are published, please feel free to scan the QR code on this slide and complete the Plastic Reduction Pledge Google form. We may follow up with you to see whether you're interested in a conversation, but there's absolutely no obligation to respond. You'll still receive a link to the resources once they're published. And so to show how this approach can be applied to a business case, we'll now look at our work on reusable surgical masks within textiles and linen. This business case explores the use of reusable surgical masks in place of disposable masks where appropriate and consistent with healthcare standards. And it's based on a pilot done at St. Marie's Hospital in Quebec, where they used reusable surgical masks from Fred Solutions, a local Quebec-based manufacturer, and the data were collected in collaboration with the coalition's partner organization, SSE. Disposable masks may contain materials such as polyethylene, polypropylene, and polystyrene. And compared to baseline estimates, the reduction potential of reusable masks averaged across non-exclusive multiple vendors is estimated to be up to 2.68 grams of plastic and about 20.5 grams of carbon dioxide equivalents per disposable mask reduced. And on a per mask use basis, the projected cost reduction is up to 70%. And I'll show you how that estimate was calculated. A disposable mask is only used once, so the cost per use is the same as its unit procurement cost. A reusable mask is different. In the pilot model, reusable masks from Fred Solutions were assumed to be usable up to 100 times, and manufacturers from many European vendors have similar certifications. And so the cost per use of a reusable is the unit procurement cost divided by the number of uses plus the laundering cost per laundering cycle. And so based on that model, averaging across multiple vendors, the estimated savings were up to 70% compared with disposable surgical masks. An important consideration as well is that reuse also affects people in workflow. So these calculations need to be considered alongside frontline perspectives and operational realities. I also wanted to briefly acknowledge a recent regulatory development. The Canadian Standards Association has released a public review draft update to CSA Z94.4 that signals a significant shift toward greater respiratory protection in healthcare settings. In the draft, respirators are proposed as the baseline for healthcare workers in most healthcare settings, except in designated exempt zones based on risk assessment. It also states that surgical masks are not considered respirators. And so the draft allows for a range of respirator options, including disposable filtering facepiece respirators, reusable respirators such as elastomerics, while also recognizing environmental and cost considerations that are associated with reusable options. So while this business case focuses on reusable surgical masks, it sits within a broader conversation about how healthcare organizations may need to adapt as respiratory protection expectations evolve. And that same principle of adaptability carries into the next section of our mask adaptation engine and break-even analysis. So this is designed for facility-specific values to be inputted and then automatically populate the corresponding placeholders that are pre-marked in the actual document for the business case. It also generates outputs like this break-even graph, which shows the number of uses required for a reusable mask to reach cost neutrality with disposable masks on a per-use basis. Some of the key inputs include factors such as laundry loss percentage, detergent cost, the number of laundering cycles certified by the vendor, current procurement volumes, and the number of staff participating in the pilot, so that you can have an estimate of how many masks you will need to procure as part of your pilot. And so together, these help produce a facility-specific estimate of costs and break-even points. Our other case studies in this category of textiles and linen focus more directly on material reduction outcomes. For example, this case study comes from a team at South Lake Hospital in Ontario. In an outpatient cardiac diagnostic department, staff noticed that linen use was higher than expected, not because of patient care needs, but because linen was simply available and routinely stocked. And so by reducing the available linen, over a 6-month period, the department achieved a 49% reduction in linen use without compromising patient care. And on a per unit basis, averaged across blankets, sheets, and towels, this translates to an inference of reducing about 0.716 kilograms of plastic and up to 0.508 kilograms of carbon dioxide equivalent emissions per average unit of linen reduced. And so we see that organizational policies supported by communication and frontline engagement can be a highly effective driver of reduction. And next, I'd like to show how regulatory change can help shape implementation success with effects that are far-reaching and that we'll do through this next category of food and cafeteria services, where one notable case study was directly catalyzed by Canada's single-use plastics prohibition regulations that are abbreviated as SUPPER in the center of this slide, which are developed under the Canadian Environmental Protection Act and have faced regulatory an industry challenge. But as of January this year, the appeals court actually ruled in favor of keeping the regulations in force. And so this slide will be included in post-webinar materials, so I won't talk through each stage in detail. At a high level, the regulations target certain items such as cutlery, food serviceware, ring carriers, stir sticks, and straws. And the sale prohibitions for these items came into effect in December of 2023. And so regulatory change can create strong conditions for operational change. At the same time, however, uptake still depends on people and organizations. Um, Research looking at consumer behavior suggests that while consumers are highly aware of the problem of single-use plastic packaging and are motivated to reduce it, that support can actually weaken when alternatives are perceived as more costly or less convenient. And so that brings us to a case study that demonstrates the feasibility and benefits of switching from disposable to reusable cutlery in a long-term care facility in British Columbia. This change reduced polyethylene plastic use by replacing disposable forks and spoons with reusable alternatives. Based on the case study and our estimates, that translated to a reduction of up to approximately 78.4 kilograms of plastic and about 49,635 kilograms of carbon dioxide equivalent emissions per year. The projected cost savings were also significant, reaching up to approximately $250,000 annually. And so our second last category is packaging, where we examine opportunities to reduce single-use plastics through changes in procedures, material use, and infrastructure change. We've organized this section into 3 areas: pharmaceutics, focused on procedure change, facilities, focused on material use, and dialysis, focused on infrastructure change. So beginning with pharmaceuticals, this business case comes from Alberta Health Services, where an emergency department, as part of a green team competition, replaced IV setup dosing with direct IV administration for ketorolac, a non-steroidal anti-inflammatory. drug under monograph specified conditions. And so that change reduced the use of IV setup materials, including polyvinyl chloride, polypropylene, and polyethylene. And we estimate that the impact was approximately 180 grams of plastic and 0.61 grams of carbon dioxide equivalent emissions reduced per dose, so per IV bag and tubing set that were delivered through direct IV instead. And the projected cost savings were up to about $23,266 annually based on a 25% reduction in mini bag use. So this diagram helps illustrate which components of the IV setup may be avoided when switching to direct IV under two conditions. So the items highlighted in the figure on the left represent materials associated with a single dose that are eliminated through the switch. And highlighted in the figure on the right, we considered situations where a patient is already tethered to an IV setup to make sure that the approach remains practical and safe. And in this case, you do still see a reduction. Reducing even a single IV bag can be meaningful, especially in light of findings such as those reported by Pardesi and colleagues in 2017, which identified particulate matter, including microplastic-sized particles in IV fluid that were packaged in plastic bags. And this figure comes from that study. Direct IV is often used during supply shortages, and so often reduction opportunities exist right in front of us, which brings us to our next branch within packaging, facilities. This case study looked at reducing the procurement of cleaning supplies delivered in plastic containers by introducing an on-site ozonator. The partner site isn't yet identified because they are still evaluating feasibility and completing internal processes. In this case, the reduction was associated with avoiding plastic containers that may include polyethylene terephthalate. Based on the documented range, the estimated impact was approximately 1,135 to 1,277 kilograms of plastic and about 231 to 294 kilograms of carbon dioxide equivalents per year. In cost metrics, we make an inference that this is about equivalent to avoiding the use of 17,000 2.5 liter containers annually, with variations, of course, in that cost for the cost of the cleaning solutions that are replaced. So finally, looking at dialysis, where reductions are achieved through infrastructure level change. This case study looks at circularity in acid delivery within dialysis through the use of a central acid delivery system at St. Michael's Hospital in Ontario. Instead of relying on individual plastic containers of acid, the site implemented centralized delivery, which reduces the need for high-density polyethylene jugs across the unit. Based on our estimates from this case, this change was associated with a reduction of approximately 1,623 kilograms of plastic and about 331 kilograms of carbon dioxide equivalent emissions annually. It also resulted in estimated annual cost savings of approximately $54,345. And so this example highlights how infrastructure level changes in dialysis can support meaningful reductions in both plastic use and emissions at the facilities level. And when approaches like this are implemented across multiple sites, the cumulative impact becomes much more significant, which is what we'll look at in this final section. When we talk about scaling these initiatives to show the potential impact nationally, should it be implemented at all facilities across Canada, one of the biggest assumptions is facility readiness that we have to make. Not every site is starting from the same place. Some facilities are at the stage of planting seeds, exploring what options exist and what might be possible locally. Others are ready to pilot initiatives, testing changes on a smaller scale and building internal experience to see if it can grow. And some are ready to excavate and plant a tree, implementing infrastructure level solutions that support larger system level reductions, like we saw with the central acid delivery system. The estimates we'll look at next are intended to illustrate the scale of opportunity across these readiness states. And when making these national estimates, we work through 5 considerations to make sure that the scaling approach remains rigorous and conservational. In brief, these steps help us identify what should be scaled, understand what drives uncertainty, and then choose the most defensible common scaling factor and apply that ratio across project metrics, and then validate the resulting estimates against external benchmarks. So the figures that follow are intended as speculative best case numbers grounded in available data and explicit assumptions. This slide shows what happens when local data are taken through the scaling framework to produce national estimates. For low-risk, non-sterile gastrointestinal endoscopy, that translates to an estimated 1.49 million in-scope procedures nationally, with a potential reduction of roughly 464,400 PL325 bottles and about 83,600 kilograms of plastic, approximately 11,371 kilograms of carbon dioxide equivalent emissions from that plastic production of those bottles alone. The associated average cost savings are an estimated just under $979,000. And for dialysis, the national scaling estimate corresponds to just over 30,000 in-scope procedures nationally, with the potential to avoid roughly 1.49 million 4.5-liter high-density polyethylene containers, reduce about 178,300 kilograms of plastic, and avoid approximately 36,365 kilograms of carbon dioxide equivalent emissions from plastic production. The associated average cost savings in this case are estimated at just under $6 million. And with that, I will pass it back to Sandra.
Thanks, Tifu. So the quantitative data shows us that these projects are effective at reducing single-use plastic waste in hospitals. Qualitatively, we've had numerous conversations with healthcare sustainability champions across the country. And in addition to that, we've conducted and analyzed 15 interviews that explores this topic even deeper. What we've learned is that these initiatives do work, and it's relatively easy to get support as to why it is a good idea for it to be implemented. From our work, we've found that the biggest barrier to implementation is actually understanding the how. How does the initiative actually get implemented in a complex hospital environment? How do we adapt a case study to different contexts, teams, and constraints? And also, how do we do it efficiently that limits disruption to workflow? And so that's the gap that we're trying to address. And that is where the knowledge translation component of the Circular Clinical Care Project comes in. What we need are practical tools that take what's already been proven and make it easier for others to replicate. And so over the next 12 months, which are the last 12 months before the end of the Circular Clinical Care Project, we will be creating implementation packages. The goal is to take what we have learned from our pilot work and provide structured, ready to use, or at the very least fillable resources, which could include materials such as project plans, business cases, calculators, communication materials, or training tools, so that teams do not have to reinvent the wheel. For hospitals that already have green teams in place, this approach can significantly accelerate the process of implementation. And beyond just saving time, implementation packages also help to build confidence and capacity. They apply learning and implementation science principles to support teams, strengthen self-efficacy, and enable collaboration at scale. And so, in short, the purpose of the implementation packages is to help turn we know this works into we know how to implement this to work here. And building on the implementation packages, the other piece of this work is creating training materials, because having the implementation procedure is only part of a solution. We also need to ensure that individuals feel confident and equipped to use them. And so our approach is to have training that is grounded in evidence-based teaching methods, which is where the use of multimedia tools becomes important. We, by combining visuals, audio, and clear messaging as to why this implementation is important and how it can be done, we can better capture attention, support understanding, and improve long-term behavioral adaptation of these practices. And so in the process of creating these training materials, we are emphasizing collaboration. We're working closely with educators, knowledge translation experts, and clinical staff to ensure that these materials that we are creating are, to the best of our ability, relevant, practical, and tailored to the real world hospital setting. And so going one step further, we're aligning these packages and training resources with the new Green Hospital Scorecard that will be released in collaboration with Accreditation Canada, Health Standards Organization, and the Canadian Coalition for Green Healthcare. So when you bring these pieces together, the business cases and the case studies that will live in these bigger implementation packages, along with the training materials, they have synergistic effects to promote sustainable change within a hospital to reduce single-use plastic waste. And so with that, we appreciate your time and engagement with us in today's webinar. Our contact information, along with the QR code to take the pledge and also be directly notified of the publication of these resources, is on the screen. So thank you, and we're happy to take any questions.